a continuation. So now we're going to talk about pacemakers. So pacemakers are implanted within the body. You can see the A is the actual power source. That's your pacemaker. And it's placed with leads. You can see the wires that go down into the atrium. There's different types. We're going to talk about the different types of pacemakers. This is just a good picture, so I kept it for the class. You got your leads. It's placed subcutaneously. So you've got your power source. You have your leads, which are your wires. This is an actual dual chamber. See that's got the two leads going, one to the atrium, one to the ventricle. And then your power source, like I said. Your pacing circuit consists of the power source, one or more conducting leads. You have an electrical signal or a stimulus that travels from the pacemaker to the leads, to the wall of the myocardium. So that'll stimulate it. And then your myocardium is where it's captured and stimulates it to contract. This is just some examples of some pacemakers, different types. You've got your single chamber. You have a lead to the right atrium or the right ventricle. So your single chamber pacemaker. Your biventricular is your lead right and left ventricle through the coronary sinus. Oftentimes the biventricular is your cardiac resynchronization therapy or your CRT therapy. And then your dual chamber, you have the lead to the right atria and the right ventricle. Your cardiac resynchronization paces both ventricles. Biventricular. Bi means two. So these are just the different types. Oh, yes. So it's used. The pacemakers are used to pace the heart, and the power source is programmable. A lot of times it's used to treat heart failure, symptomatic bradyarrhythmias, heart blocks, sick sinus syndrome, really depends on, what's going on, what type of pacemaker you have. But you can have one that paces the atrium and the ventricle, just the atrium, or both ventricles. But most fire on demand when the heart rate drops. So inside that power source is a sensing device that inhibits it from firing when the heart rate is adequate. Like I said earlier, if your heart rate is 80 and it's set to sense at 60, set to pace, then you're not going to see any spikes. So it's programmable to sense the heart rate. So I've got a picture here of a pacemaker spike. This is what type of capture is this? Right, the spike is on the ventricle, right? See how the spike is right before the QRS? So it's a ventricular capture. See those spikes? Before every QRS. Where would it be if it's on the atria? Where would you see the spikes? Before the P wave, right? And I say that, I don't think there's one that shows that, but that would be what it would look like. You would see the spike before the P wave. Pacemakers malfunction. They can. So the first one is failure to capture. The heart fails to respond to the impulse. So you see how there's a spike on some of the QRSs, but then there's just some spikes? It failed to capture that ventricle. Yep, the heart fails to respond. Yep. And then you got your failure to sense. That means the pacemaker's under sensing. So it fails to detect the atrial and the ventricle activity, but you still get a spike. You might get one on the R, you might get one in the right place, you might get one on the T, you might get one on the R. And then you have your failure to pace. That means the pacer's just not working. As you can see, you've got a long line there with nothing. I just made some notes there. You've got no QRS on the top one. On the middle one, see how it fired on the T wave there? And then at the bottom, I just drew a line where it shows that it's not working. So how do we care for pacemakers? It's important that we know about pre and post care. So pre and post, they're going to get a prophylactic antibiotic. ABX is antibiotic. Complication, prevent infection, right? You want to give them those antibiotics. So after they get the pacemaker, they're going to do a chest x-ray to make sure that it's where it's supposed to be. What else might they do with the chest x-ray? What are they looking for besides just placement? You can't answer. No, I'm just kidding. You can answer. What are they looking for? Pneumothorax, right? While they were inserting it, they poked the lung. We don't want that. They got to check to make sure. So we're ruling out pneumothorax. Bless you. So limit shoulder activity, arm and shoulder activity. Who took care of the pacemaker patient at clinical? He had on a sling. The patient did. That was to remind them not to move their arm. What happens if they lift their shoulder, they move their arm, or they hyperextend it? They can dislodge the lead. That means more surgery. That was what he was there for the first one for. He had dislodged his lead. So they cannot lift the arm and they cannot hyperextend it. So when they go to put their shirt on, they have to put this arm in first and then they can put the other arm in. So they can never put their arm behind them, put their shirt on. This is just while they're healing. They eventually can. They cannot drive till they go back for their second doctor's appointment. Like once they leave the hospital, then they go back for their follow-up. Usually depends on what the doctor says as far as when they can drive again. How much pain medicine they're taking and how well they're healing. But can't drive at first. And in the hospital, they're going to be on a continuous monitor. So if you're caring for someone that just had a pacemaker, they're going to be on ECG. They're going to be on telemetry. They should be. A lot of times they'll also have whoever the manufacturer is of the pacemaker, they'll come do some education with the patient, like if it's Medtronic or whoever's made the pacemaker, they'll do education with the patient as well. So, and they can get out of bed once they're stable. Of course, you're going to monitor for bleeding and hematoma. So not only are you just going to look at that thing, you've got to touch it and make sure it's not swelling up around it. And the hematoma's underneath. You got to assess it by inspection, palpation. Of course, you're going to monitor for a pneumothorax. How would you know if they had a pneumothorax? What if they missed it? What if the chest x-ray didn't show it? How would you know they got to your floor? Shortness of breath, right? Vital sign changes. Pain. More pain than... They'll have a lot of pain. You're going to monitor for atrial or ventricular septum perforation. That rarely happens, but you're still going to monitor for that. You may see a dysrhythmia or, again, vital sign changes, pain. I guess I worked with some really good doctors. They never did any of I've seen some pneumothoraxes, but I never saw a atrial or ventricular septum perforation. I'm sure it happens with the putting in of the pacemaker. And you also want to monitor for lead misplacement. How would you know if there's lead misplacement? Right. You'll see it on the monitor. There'll be irregularities. So what is important when you're sending the patient home? It's very important that they are very compliant with their follow-up appointments and their pacemaker checks. Their incision care. They can't take a shower until it's usually until they go back for that doctor's appointment and he gives them an okay. But usually that first, when they get discharged, they're not supposed to shower until they go follow up with the doctor. So incision care, just keep it dry. Watch for signs and symptoms of infection. All the incision care stuff that we normally tell people. Again, the arm restrictions. Make sure they're aware of why they have to not raise their arm. You know, a lot of times if people know the why, they're a little more compliant. So if you tell them, don't raise your arm, you know, you got to do this because you don't want to be back in here for more surgery. They're usually more apt to listen if they know that, you know, they may have to have surgery again. You want to avoid direct blows, and that just means, you know, no contact sports. You just don't want any, you know, you don't want to hit it, like hit your, and that's part of the reason for the no driving. You just want to avoid direct blows to the area. No MRIs unless the pacer is approved. A microwave oven's okay to use. Avoid anti-theft devices, which means you can still walk through them, you just don't want to stand in front of them, like at Walmart or CVS. Just because it can, you know, mess with the electrical current. You just don't want to hang around. And then air travel, you want to definitely notify security, because they're gonna, you could set it off. You want to teach the patient to monitor their pulse. They're not going to have an ECG machine at home. They're not going to be able to see if their pacemaker failure to sense or failure to capture. So they need to know how to check their pulse, right? To notify the doctor if it drops or if anything changes. They need to carry a pacemaker card and a medic alert bracelet or a pin or necklace. So all of these things are important teaching that we have to do to the patient when they leave. So what are temporary pacemakers? Temporary pacemakers just mean that there's a power source outside the body. You can see in the picture, that's the power source. Usually it's like a handheld power source. Can be transvenous, epicardial, or transcutaneous. And most of these are inserted emergent or used emergent, the transvenous. Epicardial, a lot of times surgery or critical care units. You see the external power source. So I've got a picture here showing y'all the difference. Temporary pacemakers. So epicardial is or some people call it transthoracic. The lead wires pace to the epicardium during heart surgery. So you got your external power source, and then see the epicardium is your outer surface. So your leads are going to pace to that. It's usually just temporary. And these will be taken out usually after surgery in ICU. Then you've got your transvenous, again, external power source, and you have your lead wires pacing to the atrium or the ventricle. Most of these are just put in emergent. Like I had a patient one time that had an internal pacemaker put in, and it wasn't working. For whatever reason, it was not working. So the doctors put in one of these, a transvenous, just until they could go back in and fix it, or, you know, put in another pacemaker for him. So this was just like 24 or 48 hour type thing. But most of these are emergent. And they're usually like just to bridge for surgery until they can get a permanent one in. Oops, what was that? Okay. And then your transcutaneous, that's the one where they actually use the pads. And you can see one's on the front, one's on the back, and then on the female, make sure you put it under the breast. Again, you still have the external power source, so you're going to have the little small machine. This is like an emergency situation, like in the ER. It's temporary. And they always use the lowest current. So maybe, you know, whatever they need for the patient to, if they want to keep the heart rate at 60, they may put it at 20. But if they need it, you know, if it's not working at 20 volts, they may up it a little to keep that heart rate at 60. But they do provide analgesia or sedation for this. Because it, you know, it's basically little shocks. We already talked, you know, a little bit about changes with myocardial ischemia. So what is ischemia? Lack of O2, right? Decreased oxygen. That case study that we did, remember? He was chronic stable angina, but when he got on the treadmill and he did a stress test, it showed ST depression. So while he was using up all that energy and on the treadmill exercising, his vessels vasoconstricted and it caused this ischemia. So he didn't really have it at rest, but he had it at exercise. So anytime you have some ischemia, you can have some ST depression. You can even have some T-wave inversion. Anytime with ischemia. The only time it's significant is if the T-wave is greater than 1 millimeter below the isometric line. A lot of times they'll take them straight onto the cath lab. And this is injury. You see how the T-wave is really hump, it's like a hump. You can't even see the QRS. So your QRS is kind of disappeared with the hump there. Yes. So you've got your lack of O2. So this person, this rhythm's going to go straight to the cath lab, isn't it? This is ST elevation. You got your QRS. Your ST is elevated. Your T looks kind of normal, but your S to T is elevated. You see how they call that the pathologic Q wave when it's actually prevalent? That right there. So your changes associated with injury. Your injury is a worsening stage of ischemia. It's potentially reversible. But it can evolve to MI. Sorry, that is really sloppy writing right there. It says can evolve to MI. If you have absence of cardiac markers, that confirms no infarction, but they're still having some ischemia, but no injury yet. But it can evolve to MI, infarction.
Where did you say that red thing?
That's a pathologic Q wave, the little red dot.
No.
Oh, it said the ischemia is potentially reversible, but it can evolve to a myocardial infarction. So it can infarct if you don't have an intervention. And this person needs what? Intervention, right? They need cath lab or what?
TPA.
Yep, thrombolytic. TP. All right. This is an infarction. See how your Q wave is even went further lower? You've got the same ST elevation, then your T wave inverts. This is showing this is damage happening. Infarction. You're going to have positive markers with this. Positive troponin, right? What's the best marker? Troponin. They do both. They do the troponin T and the troponin. Yes, they do both of those. I think it's the T that's better than the other one. It's a 1. Yeah. So the ST segment is significant if it's greater than 1 millimeters above the isoelectric line or below. I think I spelled that wrong. It's isoelectric line. What rhythm is this? Let's see. 1, 2, 3, 4, 5. Yep. It's bradycardic. You see the isometric line? See how it's elevated a little above it? I have it drawn. So you've got ST elevation. It's not elevated much, but it is a little. We're not going to trick you with a question like this. It'll be obvious if it's on the test. It'll be, I just wanted to show you how small it can be, but if it's on the test, it'll probably be something big like this. I mean, not just this one rhythm. It'll be a whole strip, but it'll look big. This, I just wanted to show you how small it can be. This is ST elevation. See the T? All right, so what are PVCs? Premature ventricular contractions. You've got a wide QRS. It's wide and bizarre. And a lot of times your T wave is inverted. It's going in the opposite direction. And it's premature or early, so in occurrence of the QRS complex. And it's just one PVC at the top, and then the second one's a couplet, so you got two PVCs side by side. You got your PVC, which is R on T, and ventricular bigeminy, which is 3, and bigeminy is 2, and then trigeminy is 3. Every third complex. And then up here at the top, back on the second rhythm strip, you've got ventricular tachycardia. So if you have 3 or more consecutive PVCs, it's considered VTAC. And a lot of times if you see this in the hospital, you'll see the nurses, or once you're a nurse, you'll get a little worried when there's 3 in a row, because that means it could convert to VTAC, full VTAC. So why do people have PVCs? A lot of times they're caused by stimulants. Caffeine, alcohol, cocaine, theophylline or breathing treatments, epinephrine, nicotine. So stimulants, stress, and even electrolyte imbalances can cause premature PVCs. Hypoxia, fever, and different disease states like CAD, heart failure, MI, mitral valve prolapse, MVP. So all of those things can cause PVCs. Why do we want you to learn how to do a pulse deficit? Because you can tell if they have a pulse deficit, most likely they're having PVCs without a monitor. You can tell that without a monitor. If they have a pulse deficit. Do y'all remember what a pulse deficit is? Right. When you check your apical and your radial pulse, and it's different. They're different. Sometimes the patient says, it feels like my heart flips does flip-flop. And it also can cause decreased cardiac output. Treatment relates to the cause. You're going to give O2 for hypoxia, right? That may help. You're going to replace those electrolytes. Electrolyte replacement. Replacement. Electrolyte replacement. I put just placement. Electrolyte replacement. Assess hemodynamic status to determine drug therapy. Possible drug therapy. You got your beta blockers, your amiodarone. Then you got your ventricular tachycardia. Okay, so we've got 3 or more PVCs that turned into ventricular tachycardia. You have a rate of 150 to 250. The rhythm can be regular or irregular. Your P waves are buried in your QRS. And your QRS is distorted and wide. It can be pulseless or have a pulse. This is considered monomorphic. See how they're all the same? Similar? We're going to talk about polymorphic too. Their complexes are going in the same, they're around the same size, shape, and they're going in the same direction. The ventricles take control. Why does it happen? The ventricles take control as a pacemaker. So they're firing rapidly. A lot of times you'll see this with MI, CAD, electrolyte imbalances, cardiomyopathy, and again mitral valve prolapse, drug toxicity. Hypotension is, decreased cardiac output. You may see pulmonary edema, decreased cerebral blood flow, cardiopulmonary arrest, pulse or pulseless. And that's what the treatment is different for pulse and pulseless. We're going to talk about that. Treatment depends on the pulse. If you have a pulse, you treat the causes. If it's electrolyte imbalance, replace the electrolytes. Drug toxicity, correct the drug toxicity. And sometimes they'll even cardiovert if they have a pulse. Same as AFib. So you can go back to your AFib. You see, the sync button is on. And you cardiovert. I think what gets confusing for people is when they have a pulse, they cardiovert. So lower joules, but when they don't have a pulse, you may defibrillate. Just think, if they don't have a pulse, you're going to start CPR and you're going to start ACLS protocols, which means shock them. Every pulseless person gets shocked. Not always, but if they have a pulse, I think you want to cardiovert that into a regular rhythm. So the treatment depends on whether they have a pulse or not. If they don't have a pulse, are you going to go in there?
If they have a pulse, are you still going to do CPR and then cardiovert?
So like I said, you're probably not going to see a rhythm like this on your test. It'll be more, if you see something, it'll be straight VTAC. This is polymorphic waves. The rhythm's irregular. You see how they're all different shapes. Your P wave's absent, same thing. Your QRS is wide and twisting. So poly, means twisting. You can see this sometimes in alcoholics, a magnesium deficit or pericarditis. You might see this. We're going to talk more about pericarditis. That's itis means infection, right? Of the pericardium. Oops.
Is that a magnesium deficit?
It can be a magnesium deficit, yeah. Mag deficit or pericarditis. And then VFib, your rate's not measurable, the rhythm's just chaotic, the P wave's not visible, it's just fibrillation waves. You really can't see much. It's a severe derangement of the heart rhythm. Why does it happen? The ventricles fire multiple foci. And mechanically, the ventricle is just quivering. Just quivering. It occurs with MI, heart failure, cardiomyopathy, shock, hyperkalemia, acidosis, drug toxicity. These people are pulseless, apneic, unresponsive. What do you think we should do? CPR, call a code, ACLS protocol, shock them. They're usually unresponsive. So immediate CPR and ACLS. or advanced cardiac life support. Most of the time, these people will get defibrillated. Most likely, they are gone. The rate's absent, rhythm's absent. It represents absence of ventricular activity. They're usually unresponsive, they're apneic, and treatment is CPR with ACLS. You're always going to assess the rhythm in more than one lead, right? Because this could be one lead and you look in a different lead and they have a rhythm. So again, always treat the patient, not the monitor, right? Treat the patient, not the monitor. Pulseless electric activity, why? It's organized electrical activity. Usually there's no mechanical activity and the prognosis is poor unless underlying cause is treated. You got no pulse, no breathing. The book says this is not a shockable rhythm, usually because there may be other causes, and we're going to talk about those. You want to treat the underlying cause of pulseless electrical activity. And that could be anything. Pulseless electrical activity, it could look like a rhythm and they're pulseless. It can be a straight line with a few squigglies. It can be just anything. It can be pulseless electrical activity. Basically, the key there is that it's pulseless. You want to treat the underlying cause. So the H's and T's of pulseless electric activity. H, hypovolemia, hypoxia, hydrogen ion or acidosis, hyper or hypokalemia, hypoglycemia. You ever been in a code and they said, let's get a blood sugar, let's get a blood sugar? They're trying to figure out what's going on with the patient. Hypothermia. So those are the H's. T, toxins. Tamponade. The ventricular tamponade. Thrombosis. Like an MI or pulmonary thrombosis. Tension pneumo. Oops. And trauma. All those can be causes. Like I said, treat the underlying cause. So this stuff would need to be treated to get pulseless electrical activity back with a pulse. I already told you a little bit about sudden cardiac death. It's death from a cardiac cause. It can be an acute myocardial infarction. It can be ventricular dysrhythmias like I was talking about. How do we want to treat it? It's also on page 762, so it talks about it in the other chapter, I believe chapter 34. But it also talks about it with these dysrhythmias. Prevention, you want antiarrhythmics, an ICD. We're going to talk about an ICD, but an ICD is an internal defibrillator. And effective CPR. prompt ACLS. Again, your AEDs help prevent this. What do they tell you? Good quality CPR. So why do we want to defibrillate somebody? To restart the heart. So they're usually pulseless if they get defibrillated, right? So what is it? It's passage of electrical shock through the heart. It treats VFib and pulseless VTAC. And you see, I have you a nice picture on how you put the pads. I actually requested the crash cart today. We're going to do some. There's monophasic. So you see you've got the current just going one way. And usually with monophasic it's 360 joules. And then your biphasic, you've got current going both ways. And it's 120 to 200 joules. And you do immediate CPR after your first shock. And before you shock, you're doing CPR. So we don't expect you all to know ACLS, but we do show you just the process of it. So your CPR, good quality CPR. Is the first step. Turn on your defibrillator. Make sure your sync button is off. This is all from your book. Apply your pads, charge, position the paddles. Remember, you got to say all clear, everybody clear. You don't want anybody to get shocked. And then you deliver your charge. Like I said, I got just a little algorithm there from ACLS. You're not responsible for it, but I just wanted you to see how it looks on this next slide. Yes?
You have immediate CPR after first shock, but then in the order of the sequence of the CPR is first.
Right.
For test purposes, is it CPR first and then default?
CPR is always first if they don't have a pulse. So the ICD is just an implanted pulse generator for someone that has high risk for dysrhythmias, VTAC, VFib. So it will basically shock the heart if needed. Basically same teaching. Follow-up appointments. Make sure they know incision care, arm restrictions. Sexual activity with this one is the same when they can climb a flight of stairs, or sometimes it'll just be when they visit the doctor for the second visit. Driving is restricted. Avoid direct blows. Avoid large magnets like an MRI. Same thing with air travel. Make sure security knows. Avoid anti-theft devices. Medical alert ID. They want an identification card in your wallet. The thing with this is caregivers need to learn CPR because they're getting it for a known reason. and what to do if it fires. So the family needs to know. If they feel sick, it fires and they feel sick, they need to contact EMS. If it fires more than once, call EMS. If it fires and lose consciousness, it's an emergent thing, so definitely call 911, EMS. So that's the big difference.
And I would assume the person would be aware of this, where like the pacemaker, they don't feel it.
Right, but when this fires to shock them, a lot of times they will feel it. Yes.
Not so much pertaining to this, but I thought asystole was a non-shockable.
All right. Y'all can take a quick use the bathroom break. 10 minutes. I have so much other fun stuff to do, but we're not gonna have time. I have fun with balls. Huh? No. My hand hurts when I'm doing this. I'm like, I think I have arthritis.
Yeah, that's. I just not look at it.